Hello, welcome everyone to this session. It's a great session. I have attended it before on low density lipoprotein apheresis for preventing recurrence of focal segmental glomerulosclerosis after kidney transplantation. I'm Michael Moritz. I'm the professor of pediatrics at the University of Pittsburgh Medical Center and Children's Hospital of Pittsburgh. I'm also an associate vice chair for clinical affairs, clinical director of pediatric nephrology, and medical director of pediatric dialysis, but most importantly, I am a user of LDL apheresis and a believer. I've used it on 3 post-transplant patients with success, so I'm really excited to hear about this and that it's offered. I introduce you Dr. Raina, who has published on just about every field of nephrology. He is a professor of medicine and pediatrics. And most importantly, he's an early adopter of this therapy. He's one of the first people in the United States to do this when the therapy was available. He's published extensively on the topic, and he's one of the most knowledgeable people on this. And I think when you learn about how LDL apheresis works, it gives you a whole new insight about FSGS. So without further ado, we give you Dr. Raina.
Thank you, Dr. Moritz. What a great honor that Dr. Moritz is giving the introduction. And let me talk about the low density lipoprotein apheresis for preventing the recurrence of FSGS. And I'll be talking in this whole talk. After taking this course, you will be able to describe the effect of hyperlipidemia on chronic progressive glomerular disease and tubular interstitial injury. And this is something very unique, and I will show in my slides, list the current technique for LDL apheresis, because there are multiple techniques available, and what is more efficacious, and identify the more efficacious treatment for removal of LDL and lipoprotein. And the third one is explain the mechanism of action and risk associated with the LDL apheresis. Now, if you look into the FSGS, it's a histological finding, and it is a spectrum. Dr. Morris can agree with that. Now FSGS is called as a spectrum of a disease, and it has various facets. It definitely presents with proteinuria and high risk of progressive loss of function. And some of the time we see the patients, they progress fast with the FSGS. And some of them respond 30 to 35% with the steroid, 30% kind of mediocre, and around 30 to 33% they do not respond with any treatment. Now, as far as the evolving trend for the FSGS is we are still doing the conservative management, immunosuppression, and mainly the determinant factor is actually a proteinuria that shows or that tells us the trajectory of the renal failure and progression. In long-term cohort studies in adult and children with primary FSGS, renal survival has been directly associated with degree of proteinuria. And that's not just true for FSGS. Any kidney disease, there's a lot of data and correlation between the proteinuria or nephrotic nephrotic range proteinuria and progression. Now, current methods for control FSGS use a stepwise approach with the normalization of urine protein excretion, what we call in a nephrology world as partial remission, full remission, or maybe complete, partial, or maybe they're not responding or non-responders. And progress in this field remains a priority in order to prevent the trajectory towards renal failure. And as Dr. Moritz was saying, we are seeing a high incidences of the post-transplant FSGS, mainly the patients who are, they do not have a genetic component to it, they are more prone. And recently we have been working actually on a guidelines for the recurrent post-transplant FSGS for adult and peds. And this new therapies have been a great armamentarium for these patients for the post-transplant FSGS. And the structure of this post-transplant recurrence of FSGS is you get very early. You get it within 2 to 4 weeks, which we call that early or primary recurrence of FSGS, and it's around 20 to 25 after the transplantation, and it leads to the graft loss. There's a lot of theories behind the mechanism how this disease can reoccur. And there was a theory of super, there are the factors, some of the humoral factor influencing the glomerular permeability. At this point of time, we do not have a strong evidence. What are the factors? What are the chemokine factors that prime these kidneys and cause proteinuria? But it's under underway and things are progressing. Now, the standard treatment is we do the steroid pulse therapy, plasma exchange, and then do rituximab, and all has been tried. And actually, you'll be surprised that post-transplant with all the standard therapy, the success rate is around 20 to 30%. Now, FSGS after transplant are recognized. It has now defined as early versus late that developed several months or a year after the transplantation, and the possibility of decreasing or absorbing the potent pathogenic permeability factors may be expected to both LDL apheresis and plasma exchange. So when this whole thought process of the plasma exchange, which is not very effective, and LDL came in, that was a process of thinking maybe we can remove this permeability factor, which could be any humoral factors that is potentiating the response. And at least super rapid recurrence occurs, such as 1 to 14 days after transplantations. And data has shown that it could be prevented with LDL apheresis. When this therapy is actually up and going in Japan, and when I was looking into the therapy and started, and we went to the FDA, we were potentially looking into the mechanism. One thing came to my mind is like, how does LDL apheresis going to work? And why, when we have other armamentarium, what is the difference between plasma exchange versus LDL apheresis? And this is a beautiful article about the mechanism. And now LDL, VLDL, and HDL, they are itself, with the oxidized LDL, can have an effect on the progression or on the podocytes. And direct effects are reduction of the macrophage, it ameliorates the macrophage dysfunction, reduction of the inflammatory cytokines. These are the things that LDL apheresis is helping. Now, apart from the direct effect on the podocyte, I was surprised to see anticoagulative effect by absorption of various pathogenic factors by the dextran sulfate. And I will go back to you to go over the various methods of the LDL apheresis. This is very important for you to know what are the various adsorption mechanisms that you're using for these LDL apheresis. It reduces the fibrinogen and coagulating factor. It increase of VEGF, N-bradykinin production, and decrease in the thromboxane A2. And it helps in the absorption of the vascular permeability factor. It enhances the immunosuppressive response, and we have seen that after the post-transplant or the patients who are resistant to FSGS. And I'll have a very nice pathophysiology slide. It actually enhances or improves the corticosteroid response by enhancement of the transmembrane cyclosporin 8 transport via lipoprotein receptor, a beautiful pathophysiology. And we have seen that response. Within the second therapy, they start responding with the steroid. And it has an inhibitory effect upon MDR1 gene expression that is actually a cause of some of the steroid resistance. And that's very fascinating. So I was at that time, and we were talking, bringing this whole process into the US. This was some of the things that we talk. And I'm just trying to go through you the process, why we have committed to do therapy and how this whole journey begins. Then we had looked into all that, and we did a huge review article on role of lipoprotein apheresis in cardiovascular disease reduction. And then the whole cascade, how does the lipid and CKD work? What is happening with the lipid? And if you look into the phenomena, the hyperlipidemia and hypercholesterolemia and abnormal lipoproteins, they're actually affecting the CKD and progression. And if you look, lipiduria causes tubulointerstitial disease, causes interstitial fibrosis. You have vascular endothelial injury that causing atherosclerosis, endothelial dysfunction, and hypertension. And this is amazing that high cholesterol, lipids, and hypercholesterolemia actually decreases adenopectin, increases IL-6, and who knows more than you all and us about the IL-6 in the era of COVID-19. TNF-alpha is increased. It increases the MCP1. These are the chemokine factors that actually cause mesangial cell proliferation, increase in the mesangial matrix. And you know, the definition in pediatric FSGS that Dr. Moritz can add on it is having a mesangial proliferation is considered to be the main cause or defined as an FSGS. And it causes macrophage infiltration. It you can see all these chemokine factors increasing the ROS causes glomerulosclerosis, progressive renal disease. So as I said before, we were thinking the mechanism, and now we have a lipid directly affecting onto the glomerulosclerosis. So I was sold out that yes, lipid has an effect on the progression at various levels, tubulointerstitial level, mesangial level, or on the vascular endothelial level. So those are the nice pathophysiology that we looked at. Now, when we were talking about bringing this machine and starting, I was convinced that it is affecting, it's going to help in the FSGS patient, but what are the benefits? And what is the mechanism correlation? So recovery of the macrophage function is important because reduced macrophage stimulation by oxidized LDL and reduction of the inflammatory cytokine improve macrophage functions. And we have seen that, and we are actually working with Dr. Smoyer from Nationwide. Now what we are going to do is we'll take these thick column and to see what they do after we remove these LDL fraction, VLDL or HDL, how do they affect the podocyte integrity? And that's kind of down the road, but I'm just bringing the pathophysiology here. And it prevents the proximal tubular injury and tubular interstitial disease because a lipiduria can initiate that process. The biggest thing that I have seen with this process is the enhancement of response to the immunosuppressions. Lowering lipid level improve the response to steroid cyclosporin due to the improvement in intracellular drug transport. Prevention of the vascular endothelial injury. It reduces the VCAM, it removes the fibrinogen and other anticoagulation, it improves the blood flow, it increases the level of VEGF, nitro oxide, and lower level of vascular permeability factors or the VEGF. And it has an anti-inflammatory effect because lowering the LDL oxidation, C-reactive protein, ICAM, and P-lectin, this was something fascinating to see in the pathophysiology. And restoration of the interferon gamma production and interleukin 12 stimulation was thought could be to the help of making the patient responsive, which are non-responded with the standard care that we have. And maybe this is all potentiating and helping kidneys, interstitium, mesangial, podocyte to heal, and they do not go into downhill because the trajectory of the FSGS going downhill is very fast. And again, they progress fast as compared to other like membranous or minimal change. I'm not going to go into detail. I have kind of explained, and this is a busy slide. I was sold, I knew this is going to be effective, and now we know what the lipiduria, the LDL, VLDL is going to do to us because we have proved there is a chemokine or humoral factors. So if I can remove the lipid particles, I'm removing any chemokine, a big macrophage. I also have looked and we did the review, we found out this lipiduria effects are not only on the podocyte, but it's affecting on multifacets like mesangium, podocyte, endothelial. The third thing is that these are having an immunomodulatory effect, affecting on the macrophage, the VCAM, affecting the interleukin. So it has a complex pathophysiology. Now that's the point when we were looking into the specific products for these LDL apheresis. I was very fascinated to see how are you going to remove this? What is a site selection? So what we found out that actually it is an electrostatic interaction. These dextrose sulfate, and they take LDL, HDL, and even lipoprotein A. And this is a nice diagram. And I was I kind of was very excited to see this because I remember my first LDL apheresis when I was doing, it was a cartridge. So you have to run 2 cartridges, and I'll come to that more detail. That was white, and immediately within half an hour, it turned into mac and cheese. It was all yellow. And this picture was depicting when I was seeing the filter, yes, we are removing by adsorption, electrostatic interaction, these huge particles. The other thing is you can see the lipoabsorber D as a direct hemoperfusion reduction based on the study. Now, why I'm showing this slide is that still there is a controversy about super chemokine factor, humoral factor, IL-6. And This is how the molecules are removed. LDL 68 to 80%, lipoprotein 70 to 78%, triglyceride. These are big molecules with the density. And whatever the chemokine factors is, if they can remove these LDL, lipoprotein, triglycerides, I'm sure the other factors or potentiated humoral factors will be removed. And what a good example we have now is the Oxyrus. And I have used Oxyrus in COVID-19, and immediately in 12 hours, there was a reduction in IL-6. And that's the good example of the adsorption. At that time, when I looked into the fragment that they're removing, I was pretty sure any humoral factors that's contributing will be removed. And that's why there's another term we use is selective adsorber, where they have LDL, lipoprotein, and triglyceride, and these are heavy molecules. Now, if you look into, and this is very important for you to know, there are various ways of doing the LDL apheresis. And this is a slide I like, and I put in my review too, is you have to correlate these efficacy by the LDL molecular weight or LDL removal, because LDL is a big molecule with a lot of Daltons. And if you see the dextran sulfate cellulose adsorption, the reduction is 76 to 81%, and lipoprotein 65 to 80%. It's widely used in the management of drug-resistant nephrotic syndrome and familial hypercholesterolemia. You can use heparin extracorporeal LDL precipitation, which is HELP. Some people have used direct adsorption of lipoprotein, but you see the efficacy in the setting of the dextran sulfate cellular adsorption is much higher, and the data is already there. Now, the good thing is you can use the 5% sodium chloride, which is used to generate the column, and heparin is used as an anticoagulation. So this all data and synthesis, when I was doing, I was very convinced that this is the mode that I should be using for removing of the LDLs or lipoprotein, which will be dextran sulfate cellular adsorption. Now, I want to really take 1 or 2 minutes about to understand albumin-associated free fatty acid-induced macropinocytosis in podocyte. And this concept came mainly in the setting of the diabetic nephropathy in the model. And I want to bring that because this is very much correlated with a lipopheresis or LDL apheresis, is podocytes are capable of internalizing, just taking and absorbing these large amount of extracellular fluid and molecules by macropinocytosis, and they are non-specific process that result in a small vesicles in diameter and involve both coated and non-coated. And active clearance of this mechanism to prevent the filter from clogging, and podocyte is playing a specialized role in uptake and removal of these plasma protein that crosses the glomerular basement membrane. And this is a good example for you for the lipid LDL apheresis. A significant urinary loss of albumin decreases the plasma lipid buffering capacity, causing an unbound FFA, which is a free fatty acid. Now, what does this free fatty acid does? It increases the circulating ANGPTL4, which inhibit the lipoprotein lipase and therefore lead to the plasma triglyceride. So our regular teaching is if you're confused between nephrotic and nephritic factors, check the lipid and their cholesterols are very high, then you're alluding towards a nephrotic, not nephritic. And this is how the mechanism and how they inhibit the lipoprotein lipase. And then when these ANGPTL4 express in podocyte, they induce proteinuria. We still don't know the mechanism. And excessive macropinocytosis and accumulation of albumin in podocyte lead to lysosomal dysfunction and podocyte loss. And that's what we see, what we call now is the maladaptive response, which we see in FSGS, where you have actually the pore and the podocyte injury. So when we put this structure of this micropinocytosis with the LDL apheresis, podocyte injury leads to albuminuria and hyperlipidemia. This leads to increase in FFA, free fatty acid, and albumin ratio, causing vicious cycle of persistent podocyte damage, and albuminuria converts proteinuria into nephrotic syndrome. So therefore, we are convinced that the lipoprotein apheresis to lower the lipid level could, in theory, reduce the proteinuria and improve the renal function. And that is something we are looking for. And I said before, the proteinuria is the potent mechanism for, or there's a correlation with the worsening proteinuria and progression of the renal failure, or sorry, progression of the CKD. Now, these are some of the things that it has been approved, and now it is also approved for adult. At the time when I was doing the study, it was approved for FSGS. It is also approved for refractive hypercholesterolemia, familial hypercholesterolemia, FSGS, standard medication resistance plus LDL more than 250. So these are some new use of these, the indications. And the indications for familial hypercholesterolemia, peripheral artery occlusive disease plus FH was there before, and now we are actually transitioning those standard care or standard indication to the FSGS. And this is how the lipoabsorber is. As you can see, this is a blood pump. You have heparin. You manage the ACT or the test, which is a point of check. And these are the filters. If you can see, these are the lipoabsorber filters. And I said when we were doing this, I was surprised the first patient, within half an hour, the whole filters were like mac and cheese loaded with lipids. And that shows the efficacy. Now, a lot of you people have asked the protocol, and I'm sure Dr. Moritz used the same. Therapy is done 2 times a week for 3 weeks, then once a week for 6 weeks. Plasma volume to be treated is determined by multiplying patient weight in kilograms by 60, and then result is rounded up to nearest 100. And the priming solution you need to know is 2,000 to 3,000 USP unit of heparin in 1 liter of ringer lactate, and loading dose of heparin is 25 and unit per kilogram. Reduce the dose of abnormal PT and APTT, and continuous heparin infusion is 25 unit per kilogram per hour, and we use the activated clotting time monitor during the initial few sessions. ACT should be maintained around 1.5 to 3. I keep it around 2 to 2.5. And this is a dose we calculated. If you normally have around 1,000 to 3,000 USP unit of heparin per hour is adequate and pumping using heparin infusion to the blood withdrawal line. So this is the protocol if you want to initiate or discuss about the study. Now, using LDL apheresis to treat nephrotic syndrome, in a sense, nephrotic isn't common the endpoint of the podocyte injury. It doesn't matter. There could be 1,000 mechanisms of podocyte injury, and this is not the area of talk. But one example is that patient would otherwise need nephrectomies, dialysis, and then transplant with the risk of recurrence. Could LDL apheresis allow the patient to keep their kidneys? Another example is a congenital nephrotic syndrome, which is a nephrin defect, and it's so hard to manage these patients. So this is how this study was already going. We have studies even before 2007, and you can see these are number of studies by number of authors. Some are prospective, some are retrospective. I really want to tell here the mechanism is mainly the most important cause of the disease was the FSGS, but there are some diseases with with membranous nephropathy, and you can see some of the cases are IgA, but they're always saying they're resistant. So the thing is, these patients were given all the treatment. Despite that, they were resistant, and you can see the efficacy of this treatment, even going back to 2007, was ranging between 54 to 76 to almost 86%. And what we had at that time in US, the efficacy was 25 to 30%. And post-transplant recurrence, the biggest concern is the loss of the allograft. And anything we do, plasmapheresis, rituximab, the efficacy or the outcome was 25 to 30%. So this was something very fascinating. So I know the mechanism, I know which filter I have to pick. Now I know the podocyte injury. Now I also understand I have the full proof what we are removing. Now I have the clinical studies, which has been done since 2007. So I was convinced. This is a very good study by Hattori and group, and you can see with the follow-up time how the proteinuria is going down with the lipopheresis. And this is length of the follow-up. You can see the GFR is well maintained. And so this is just the progression with the evidence, and this was done in 2003. So what predicts a response? This is the question that we have in FDF. Okay, we'll go to this therapy. What is predicting the response? And this is a very beautiful concept. I want to put it there is a degree of tubulous to interstitial lesion. The lower, the better. What they were using according to Cameron-Bladford method using the following formula. And only limitation was the line infection. We have small numbers, and there was spontaneous remission or PDN response. This is how the improvement of protein and serum protein was. You can see the difference, like 8.7, 8.2, 6.2, 2.7. This is LDL group. This is just the standard treatment group, 2.8 to 2.9. It's kind of everywhere scattered. But if you see before or after the LDL group, that this is steroid monotherapy and this is LDL group, there was a huge difference in the proteinuria with LDL apheresis. And the clinical efficacy of LDL apheresis nephrotic syndrome, this is again, if you look into the various treatment protocol, they were all giving a pulse steroid after the treatment. And as these data shows that these patients after the LDL apheresis, they're very receptive to the steroid. And I'll come to that mechanism too. But see the efficacy and indication, most of them were FSGS, somewhat minimal change, and one or two was minimal change, sorry, the membranous, but some of them were minimal change, but they have mesangial deposition of IgA, which according to the pediatric theory, if you're not, pediatric nephrology concept, if you're not responding to the steroid and you have mesangial deposition, you're evoluting into the FSGS. Therapy of the, you can see this is a big trial that I really trust and look into the 11 pediatric patients with steroid and cyclosporine-resistant FSGS. And I was looking into the response in children, and LDL apheresis was given twice a week for 3 weeks, then weekly for 6 weeks. Short-term effect was LDL on hyperlipidemia, urine protein ratio, protein to creatinine ratio, renal function at 3 and 9 months. And long-term effect was the GFR, because everybody says, okay, we can do the treatment. How long it's going to last? What was a long-term outcome? And this is a nice study, went up to like almost 11 years to look. And you can see that the partial and complete remission was standing. 7 patients remission as 5 patients complete within 4 weeks and 2 with partial. There was no major complication. This is a study which was known as the Polaris, or this Polar study, sorry. It's a prospective observation study on long-term LDL apheresis on drug-resistant nephrotic syndrome. It was a multi-centric prospective, 47 patient enrolled. And again, this is not very uncommon in any of the pediatric studies because of the less number of the patient, but these are also unique, has been treated and they're resistant. An observation study in ordinal clinical practice, there was no study protocol, physician discrete oriented, and short-term effect was 1 month and long-term effect was 2 years, non-effective 31%. And again, looking into the proteinuria level, which is called, we call that as partial responders 21, and complete responders were like 31%, sorry, 21% complete, and partial was around 31. So if you combine together, the range was almost coming around to be like 53 to 54. And that's what I showed in your earlier presentations. They were ranging between 56 to 86%. And that variability was about the patient's population. It was case reports and some of the heterogeneous distribution of the patient. But this is a good number. No effect was only 27%. Incomplete remission, 25%, 1 or 2 defined on the level of the proteinuria. Complete remission was 25. If you combine all together, the remission rate with complete and partial, when we get more stringent, was almost 67 to 70%. And this is very, very 63 to 64%. This is important for you to know. Now, this is another thing I really, really like in the LDL apheresis action by restoration of the cellular uptake and inhibition of drug efflux. So what happened is that when the steroid resistance is a very novel concept, and this was actually came out in Acta Biomedica. What happened is that MDR1 gene causes the resistance to the steroid. LDL apheresis actually represses this MDR gene and increases the elimination of the glucocorticoid. And also it upregulates the GC receptor and modify the nuclear import of the HGR and glucocorticoid. So suddenly after 1 or 2 treatments, so we give like the maximum dose, if it's an adult, around 1 gram, IV solmetrol after each treatment, and we see the response were better. And this is because of the restoration of the cellular uptake and inhibition of the drug effects, and they potentiated the response of the steroid. And this was very fascinating to see. You can see that as the lipid level is normalizing, not only steroid, the cyclosporin trough levels were increased by normalizing the serum lipid level. They are more receptive, as you can see. There is an inhibition or repression of the MDR1 gene, which is reasonable cause of any glucocorticoids effect. And these patients, they get more responsive, and some of them, they start responding to cyclosporin, not post-transplant, the one which are resistant before. And some of my patients, they start getting better response. And this is an amazing slide to show how the cyclosporin trough levels were increased by normalizing the serum lipid level. Summary of the LDL apheresis: long history of treatment in adult and peds, rapid and long-term therapeutic effect, improving the nephrotic syndrome with delipidation, and there was several guidelines in Japan. So at that time of the time, when we go through the process, when these things are coming in, the LDL apheresis, we have identified multiple steps. Number one, what is primary and secondary FSGS post-transplant? Drug resistance FSGS. What is the mechanism of these FSGS? What are the humoral factors? What are podocyte injury? How does lipid affect? How does removal of this lipid apheresis, a lipopheresis, going to help our pathophysiology? So we figured this out at multiple levels: podocyte injury, mesangial, and also endothelial. And then we have a data which is not only was proven in other country, but that this is working in our subset of population. So whenever I talk about any study and data, I always say you can take the data from a different subset of population, but you need to be very careful and cognizant that data and the data point is working for your subset of patient. So this is something was up and running, and then you have to go for a humanitarian device exception, and it is authorized by the FDA. Law for use in treatment of pediatric population with nephrotic range proteinuria. Now, when we were enrolling the patient in these studies, they were very clear that standard treatment option, you have to show that they failed the steroid or calcineurin inhibitor. I train more in tacrolimus area, but definitely there are certain people, or some of the people are very comfortable with cyclosporin. They're unsuccessful or not well tolerated, but the patient's GFR has to be more than 60. Or the patient is a post-transplant reoccurrence of FSGS. And I'll tell you a story of a patient that I have. It is, this is the reason actually I got involved in the study, is that my nurse, when I was like a baby, I was a resident, and then she evolved into a nurse practitioner. Her son, I was seeing him when I was in a nephrology, and he has this FSGS, and he progressed fast. He has no genetic variation. He was transplanted because he failed the treatment. And what happened, within 1 or 2 weeks, he had a reoccurrence of FSGS. And I was traveling with this family as a resident to the fellow, and I was like, oh no, he's going to lose this function. His genetic workup is negative. So we did the treatment, and this person before the transplant was resistant to steroid. He failed cyclosporin. He has a lot of side effects, so we changed it to tacro. We gave him rituximab to an extent that he did not respond, and he went over to the dialysis because his kidneys were progressing. He was 21-year-old at that time. So we have a live-related donor transplant that was done to him. And that was the saddest day I have. I said, no, not for him. He has gone through a lot. And that's the time the therapy came in. We did the lipopheresis. And with all our group effort, he did not lost his graft, and he's still doing well. He still have proteinuria 1 to 1.2 gram, but the graft is functioning well. He did not need the other repeat transplant. And there is another patient I have who has got everything. She got rituximab, steroid, anything you talk about was given to her. And then she came to us and we did the treatment. And so far she's stable on that. And the cutoff was the GFR was 60. So this is another problem on a not post-transplant, but a resistant GFR with all the treatment. It's hard to keep the GFR of more than 60 because some of them, they have some problem or issue with the GFR. But that's what the HDE came up with, and we supported it. And this was an inclusion criteria that FSGS or GFR of more than 60, refractive nephrotic syndrome, in which standard treatment options are unsuccessful, standard treatment options are not well tolerated, refractory or recurrent nephrotic syndrome in which standard therapy is contraindicated, and pediatric post-renal transplant patient with nephrotic range syndrome associated with primary FSGS. So these are some of the buzzwords when you go and apply for the approval for these devices. You need to document very well that patient is refractory or its standard treatment is not well tolerated. So this is our paper, and we have the chief editor actually from the journal who we have published this, and it is the dextran sulfate plasma adsorption lipoprotein apheresis in drug-resistant primary FSGS patients, result from a prospective, multicentric, single-arm intervention study. And this was a study, and we have around 14 patients from the 6 site who have been enrolled in the study. And we have done everything on these patients. The one I involved was like got rituximab, steroids, cyclosporin, and tacrolimus. We added MMF. They were failing. They were not naive FSGS walking to your office. Total of 11 patients, including 5 protocol deviation, completed 12 apheresis treatment over 9 weeks. At 1 month follow-up, 25% attained partial remission. Further, 2 out of the 333 and 2 of the 200% had partial complete remission, 3 to 6 months follow-up respectively. Only 1 patient who was followed up to 12 months had complete remission from nephrotic syndrome. And we are looking into these patients, how they are. They did well, and they started getting more responsive to the cyclosporin and steroid, and so far they were doing good. And the GFR was preserved in more than 100% or almost all patients. These are some of our patients that I put in here to show you the GFR and the trend, the baseline protein to creatine ratio, and what was the change. Now, unfortunately, the creatine doesn't tell you anything about the FSGS. It's always the proteinuria, right? Most of these patients, their creatine was fine, and the GFR, some of them were having hyperfiltration. You can see the GFR was almost like 153, and that's worse too, because once you have a hyperfiltration, it's going to go down, it will get worse, and then they progress the more easily than compared to anybody else. This was the study which is done in the Asian population, where they did the perioperative, the LDL apheresis for preventing a recurrence of the FSGS after the kidney transplant. Now, we are not doing that preemptive, but we are doing, and I'm sure Dr. Moritz can give his insight. He has done it in 3 patients. We are doing post-transplant, but just want to let you know, there is a pre-operative LDL apheresis, which data has shown you do LDL apheresis, give tacrolimus level and MMF, and then you go for rituximab and the induction with bislicimab. We are not to that level, but there is a data for preemptive LDL apheresis. A lot of patients, they ask me. And perioperative low density apheresis, you can see cases there, quantitative urine protein at 1 month after the transplantation, and what happened to the latest qualitative urine protein recurrence and qualitative urine protein at 1 month after the transplantation, with preservation of most of the GFR, ranged from like almost 38 to going as high as 91%. See the response days after the LDL, 2 sessions per week for 3 weeks, and then you do daily. What a good response with the proteinuria. This is a study by Zarevsky. We have contributed the patients to the registries, and you can see this is exactly happened to 3 of my patients, and actually one of them is now adult. And this is a response you see with a profound decrease in the urine protein creatine ratio after the transplant recurrence. And that also proved, and that's why I went over with you the process, what I was thinking, why the machine came in, what LDL apheresis are you using, what is an efficacy, this is a good example of the transitional research, and it was shown that the patient respond, and it has persisted so far. 3 years down the road, patients are persistent with the response. Some of them get partial. My patient got, 2 of them got a partial response with a proteinuria of 1.5. Well, post-transplant, within 2 weeks, they were 12 grams. So I will take 1 to 1.5, and they responded with the immunosuppressions. Luckily, with the post-transplant, they're on the steroid and tacrolimus, which is also a treatment of post-transplant recurrent FSGS. So it's easy. You can balance the kidney functions, the allograft and the FSGS together. Initially we use higher dose of the tacrolimus level post-transplant. So maybe that is also a good way of treating and masking the effect of these humoral factors for the FSGS. So this is a paper which is published by the Jareski. Sorry, it's not unpublished, it's published now. These are 3 months, 9 months, 5 months, 1 day, 18 months, 9 days. So these are some secondary 2 and total durations of the LDL apheresis what they are too. This is a nice diagram depicting the effect of these patients, how the proteinurias are. Maybe there is some chemokines factors, some heavy molecular weight proteins that's kind of causing the leak of these membranes and recurrence. And you will be, it is so fascinating, post-transplant, you see the pathology, which is same as a minimal change. They have just put effacement, nothing else. Secondary could be after 2 years or 1 year, that's confounded by the immunosuppressions and vascular changes. But the naive, the first that comes up post-transplant is just effacement of the food process, exactly like minimal change. And there was sometime a debate, should we do the biopsy to prove that? Well, you still have to do the biopsy. And very soon, our guidelines will be coming out for the management of FSGS post-transplant recurrence. And we are talking about the extracorporeal therapy. People do debate that they do plasmapheresis because they do not have these kind of dextran sulfase-based absorption, electrostatic removal of these lipoprotein. But with plasma exchange, the response was not very good and patients were not responding. But if you have that modality, yes, this is something you can use with the same concept. But the response was very profound in the setting of the LDL apheresis with the patients who did this. The other thing is that if you look into, these are the most recent GFR after LDA completion and time of the most recent onset follow-up since LDL. The longest that we have in this group was 25 months, and that's also 2 years back. So people are persistent and they are doing very well on this study. Now, to conclude, I will give 10-15 minutes for your discussion. LDL apheresis is a novel therapy, and actually it's not novel. People are knowing about it for the drug-resistant primary FSGS and post-renal transplant primary FSGS recurrence. However, long-term evaluation of outcome in a large study is required to confirm these findings, and actually people are believing on it. And this is a study which shows that you have 3 to 6 months, the partial or complete remission was almost reaching into 33 to 100%. And there is a stabilization of the GFR maintained. And giving these interim results, food analysis after the completion of study will shed more light on the outcome at LDL apheresis using the lipoabsorber. These are some of the places that we did this studies, and these are our colleague to kind of do the multi-center approach. Couple of things I want to reiterate and just want to let you know, those filters are easy to get. The anticoagulation, because you're using 2 filters back to back, so the clotting is extracorporeal is high, but using the heparin, it works well. And 3% normal, 5% normal saline, you can have in cleaning the dextran sulfate filter. So this is something we really need to use for post-transplant of the patients who are resistant to FSGS, because right now we don't have any armamentarium. And as I said, all the efficacy of the drugs that we use, including plasma exchange, is 25 to 30%. And this is how the trajectory was by, I believe, in the LDL apheresis. I showed you the pathophysiology, then evidence, then clinical studies, cohort study, and now how we did our study in US, both resistant FSGS and post-transplant, to show this does work in our subset of population. At the end, I want to thank you all. And this is, you can go for the MOC credit, which is available online through Opus Medicus. In your browser, go to the opusmedicus.com, CME/CME/246. And to claim credit, you have to take the exam. I'm sorry, and evaluate. You have to answer the questions, evaluation and certificate. And the slide is available for your reference if you attended the webinar. Viewing them is an optional. For credit, you only need to take the exam, fill out the evaluation, claim credit, and download your certificate. Thank you again for giving your evening time for us to listen our journey of the LDL apheresis. And any questions, any concern, I get a lot of emails and talk. People are reaching out to me. And actually, I'm surprised a lot of international people, even the group of the people, they have joined today is from India, and they have a lot of patients with the resistant FSGS and post-transplant, and they are actually looking to bring these devices even to international forum. And so again, you have to convince yourself. This is how my chairman told me, when you take into new therapy, you need to do your investigation. You need to be convinced what you're doing. And once you're convinced, you have to convince yourself first before taking the adventures and putting the therapy. Get your homework done first, and you can see the process, how it started. I look into the cardiovascular, then I look into the pediatric, then I look into the data, and then I worked around on an in the national level, multi-center, to prove whether this theory of lipiduria, LDL apheresis, works for our population. And thank you again. And thanks all my research fellows and my colleague who have joined, and also all the pediatric nephrologists, and also the international community. It's too early for them, and I really appreciate for you all joining. I will defer the podium to Dr. Moritz for questions and discussions.
Yeah, I neglected to tell people at the beginning of the talk to please put your questions in the Q&A. There is a Q&A chat button, so if you have some questions, please put that in. And, you know, Dr. Raina, that was a great talk. I didn't realize that you were central in bringing this to the United States. So that is terrific, so that we have the therapy. Until some questions go in the Q&A, I will ask you a question. A significant number of patients had partial remission. When do you consider using a second round of LDL apheresis? You know, if one round of therapy brought partial remission, when would you consider a second round? Or do you think extended apheresis may benefit some of the people who were resistant?
What a great question. And this, I have actually done extended therapy on one of the patients I was talking to you about post-transplant. So if you look into the partial remission term that came out actually from David Saland's paper on the membranous and with Akhtar, and he was saying partial remission is between 1 to 2 grams, and then complete remission should be less than 0.5. And that is very much transformed into FSGS. I will definitely suggest for extended therapy when your proteinuria is not going down after the treatment protocol that we have, less than at least 50%, because maybe we need more intense therapy. Now, there is no cutoff or a time limit to say how long you do it. I think I want the proteinuria at least to go down below like 30% what you have initiated. And that is pretty good ballpark for me to stop the treatment, the extended treatment, and then add the immunosuppression, standard immunosuppressions with the calcineurin inhibitor or steroid. Because you have to understand, we cannot, there is a port that we have to put in for the dialysis port, which is a MOC catheter in adults and regular dialysis catheter. These kids are very prone for any kind of clotting disorders because they leave or they lost antithrombin factor 3. So those are the things which comes in place. And with that extended therapy, a lot of the time people, and we had the same thing, and I was talking to JJ the same, which he's moved to the different facility, and he's, I don't know whether he does LDL there or not, should we anticoagulate these patients with having a port there and proteinuria? And we did not. And none of my patients have any clots or DVT, and despite having a proteinuria almost going to 20 grams. Second part to your question is, I will definitely support extended post-transplant. Anything you and I can do to prevent the graft, we'll do it.
Mm-hmm. And it's fascinating what you were talking about, explaining how the LDL apheresis makes someone from steroid resistant to steroid responsive. In the unfortunate situation that someone who responded to LDL apheresis then has a relapse, do you believe that the LDL apheresis kept them steroid responsive? Would you just treat with steroids, or do you think, or with immunosuppressive therapy, or do you think that another round of LDL apheresis is going to be needed in those situations?
Wow, these are such a good question. This is another one that came to us with one of our patients. He responded with the steroid. He did very well with the tacrolimus. Now, this is not post-transplant, this is resistant FSGS. And suddenly we saw that the response was going off, and I could not, and response lasted for about 6 to 9 months. And if you look to that article that I showed, the slide, the diagram that I put it in, the MGR1 gene, and there's a lot of data on actually on the patients with the asthma and all this repression of the MDR1 gene. I don't think we had long-lasting effect. What we can get with the lipopheresis is around 6 to 12 months. So if they relapse, I have a patient who went from 1.5 to 8 grams, then went to 12, then to 15. Then what I suggested is, and patient moved actually from here, then I gave him a standard treatment and he got better. Now, my experience, and you have more experience than me in the post-transplant, I think they do very well post-transplant FSGS because they're like a naive new FSGS. The problem with drug-resistant FSGS, we have thrown a kitchen sink on them. They got rituximab, they got a steroid, they got anything you talk about. So those entity, I think the repetition would help, and the extended is better in a post-transplant. And I do everything to prevent the graft. And you have seen in the registry, most of these patients, they still have the graft functioning. They are not like they're going into the failed transplant and looking for another in 3 months, which the chances are pretty high. I hope that answers your question.
Yes, and for the people who are on the call who may have never used LDL apheresis before, but maybe they've used plasma apheresis, if you've used the two, how would you describe the two, comparing the two from patient satisfaction, tolerability, intensity, duration, just so you could give them a sense of,
right,
what it's like using one versus the other?
Right. So it's not that I'm saying plasma apheresis doesn't work. It does work because that's what we have before, and we still, some of the centers do not have LDL apheresis. And luckily in Ohio, we have it within 2 hours proximity. You have it, but most of the centers, they do not. So at least what my experience is with LDL apheresis, the mechanism with lipiduria, lipid LDL apheresis, I have more evidence-based what I'm removing, and I have an outcome assessment. Plasma apheresis works too. You will get some people, they do respond, but with that, I do not have a lot of the evidence how and what we are removing, what is an objective of removing, at least in LDL apheresis, the objective, this is what it is, you have an LDL coming out. Intensity-wise, both of the treatment, if you have a structured stuff, it does go well. As I said, a lot of the patients did it well, and managing, and you have done that too, managing bedside ACT heparin is not a problem. There is some issues with the 5% normal setting. You need to prepare them in advance. And with the pharmacy, that little bit lead intensity. If you talk to me, the intensity and the workload, I think plasma apheresis is standard. They come and do it. With this, you need a preparation. You need to have a bedside nurse. You need to have the ACT available at the bedside, 5% solution. So there's more involvement of the pharmacy, other paraclinical or clinical staff to run the treatment and to observe. So those are some of the practical points to bring into it. Cartridge is very good, and we never had an issue for the supplies. Now, when we were doing the treatment, I kind of assess whether each treatment, the cost, and I think the people over here, they know more, is around 1,500 to 2,000. So that concept, oh, this is very expensive, this is going to be 15,000 treatment, that's also not true. If you look into the supplies and all, it is a pretty doable treatment in that regard. And but definitely the workforce and the people involved are a little higher in this setting of LDL apheresis because people are not used to the plasma apheresis. Plasma apheresis is easy and it can be done with one person involved. But again, if you look into the pathophysiology and the convince and outcome and look for the quantification, I think this has more better theory and better outcome. But it doesn't mean that plasma apheresis doesn't work. So do whatever you have in your hand in your institution.
Terrific. Well, thank you so much. Does anyone have any questions? And thank you for so many attendees showing up. It's been a really great turnout.
Thank you. Thanks a lot. Tom, anything else? Any questions? Any concerns? Tom and Jen? Okay. Thank you, Dr. Moritz, for giving your time. It's an honor for you to chair my session. I'm really very obliged, and it's always nice to see you. And thank you all, and all the people from the outside the US coming in too early. It's like 4 or 5 a.m. for you, and thank you. And I really appreciate your support and help. Thank you.